Good morning, ladies and gentlemen. Very pleased to finish up the symposium today with a discussion on what clinical trials we have today and what clinical trials we really need to have in order to meet the huge unmet clinical needs in patients with intrahepatic cholangiocarcinoma. Now, these are my disclosures. Now, as you know, intrahepatic cholangiocarcinoma is defined as cholangiocarcinoma arising above second-order ducts. That's a very important point for treatment because the definition is totally anatomical, with no correlation with biology, no association with molecular pathways, and totally no association with etiology. So this is one of the main challenges. Now, it is a relatively rare tumor in most parts of the world, less than 6 per 100,000, but it is exceedingly high in some places, for example, China, South Korea, North Thailand, and most patients are predominantly Asian. It's actually an Asian disease. And this difference in incidence is related to the different prevalence of risk factors. For example, Thailand, which has the highest incidence of ICC in the world, is closely related to endemic liver flukes. And if you look at the map of distribution, this is quite stark. In most parts of the world, it's an extremely rare disease. But if you look at Northeast Thailand, it's 85 per 100,000, more than 10 times the global incidence. And to be able to meet the huge unmet needs in this group of patients, it's good to look at what our current therapies are so that we know what clinical trials are required to address this group of patients. Early disease, surgery is important, and we are surgeons here in this audience, but you know that the 5-year outcomes are all dismal. Not all. If you can get a good R0 resection, patient live relatively well. For example, this patient with an R0 resection is 9 years into his survival. There may be some role for capecitabine as an adjuvant therapy, but generally no good adjuvant therapy, which is one of the reasons the survival is so poor. Many of them are locally advanced, and here, as Dr. Salam has said, it would be local regional therapy, TACE, yttrium-90, external beam radiotherapy. The results could be improved. Juan Fale, in his large study, has established GEM-CIS as the standard of care for advanced HCC, median survival 11.7 months. And another study using GEM-TS1 has shown that this is non-inferior to GEM-CIS. So that's where we are today. And one of the biggest problems with this disease is that it's really very heterogeneous, not only between patients, between countries, but also within the same patient. But if you look at the way we treat this cancer and the way we run clinical trials, we are treating intrahepatic cholangiocarcinoma as if it were a single disease entity, which is clearly not. In fact, many clinical trials that include ICC are designed for all kinds of biliary tract neoplasms. ICC, perihilar cholangiocarcinoma, distal cholangiocarcinoma, gallbladder cancer. They are not necessarily the same thing. And we have very few functional studies today to confirm which relevant molecular pathways are involved. And in fact, this is one of the few cancers where you have no validated biomarker at all. And clinical trials today continue to treat these patients as if they were a single disease entity with no genomic subtypes. Now, the most detailed study on the genomic subtypes on cholangiocarcinoma is the 10-country study led by National Cancer Center Singapore on behalf of the International Cancer Genome Consortium that looks at 489 cases combining whole genome sequencing with targeted and exome sequencing, copy number variations, gene expression, and DNA methylation. And taking all this data into account and integrating them, we found that cholangiocarcinoma falls into 4 clusters, driven by separate genetic, epigenetic, and clinical features. And this is important because it is not a single disease. And if you look at the clusters in more detail, the fluke-positive cholangiocarcinomas, mainly in Asia, are really enriched in ERB2 amplifications and TP53 mutations, whereas the fluke-negative cholangiocarcinomas, like those we find in Singapore and most parts of the West, have high copy number variations, high PD1 and PDL2, very important for immunotherapy, epigenetic mutations, ID1, IDH1, which is mentioned recently, and of course, also FGFR mutations in this group of patients at all. And in classes 1 and 4, they are most clearly distinguished by patterns of genome-wide hypermethylation. So in fact, epigenomic approaches can be very useful in some of these patients. But if you look at the way that we do clinical trials of them, very few of the trials actually take into account the genomic subtypes. These are the phase 1 studies. I'll go through the trials and then go into the individual treatments separately. I'll pay more attention to phase 2. You have targeted therapy with apantinib. You have one of the few targeted trials with ARQ-087 for FGFR2 gene fusion positive cholangiocarcinomas. And we know that this is found in one particular group. Cluster 4 will be where these patients will actually be upregulated. And then there are various trials, so liver transplantation as a clinical trial, and then trials where you have addition of other therapies on top of GEPSIS, and immunotherapy trials also including, for example, the Tecentriq, nivolumab, and of course EP. And many local regional therapies, 2 trials with yttrium-90 followed by GEMSIS, one by the Chinese University of Hong Kong, and the other one is a pharma trial by Certex. Trials combination of GEMSIS with TACE, GEMSIS with irinotecan-loaded beads, and a study with hepatic arterial infusion from MSK, I think our colleague just described. And other phase 3 trials from Peking, apantinib again. Of course, another trial also featuring a P10 deficiency, but we don't find much evidence of that deficiency in the studies that we've done. Now, many trials on targeted therapy, and these trials tend to be targeting VEGFR and also FGFR2. And there is some evidence that this might work at least in the FGFR2 because cluster 4 of these patients, you could see significant upregulation of this biomarker. And lenvatinib is also a dual purpose drug in the sense, so lenvatinib would potentially be useful in this group of patients because they will target that. And lots of immunotherapy drugs, Tecentriq and so on, and also bevacizumab to open up the arterial supply so that the drugs can reach them. PD-L1 expression has been reported to be upregulated in between 46 to 63% of the tumor microenvironment of this tumor. And if you look at the Keynote 028 basket trial, 41% of patients were PD-1 positive, of which 24 were biliary cancers, 20 cholangiocarcinomas, 4 gallbladder cancers. And when these were treated, there's a 17% partial response and a 17% stable disease. So there's some suggestion that immunotherapy may be useful in this group of patients. But as we can see from the big genomic study, upregulation of PD-1 is not seen in all cases, and it will be useful to have a biomarker-directed therapy in these trials. But if you look at all the immunotherapy trials that are ongoing or have just been completed, in fact, none of them are actually biomarker targeted, so it's a little bit of hit and miss. A very interesting small study presented at ASCO GI this year using lenvatinib in combination with the checkpoint inhibitor. This was a single-center trial, very small numbers, but they seem to have a very good disease control rate of 92%. And this is useful because if you look at the clusterings, the genomic clusterings of cholangiocarcinoma, you will see that in the cluster 3, PD-1 is actually upregulated, and in cluster 4, FGFR2 is also upregulated. So a combination of lenvatinib and immunotherapy in terms of checkpoint inhibitor may be useful in this group of patients. This is a BILCAP trial, a little bit controversial. This is an adjuvant study, and we really do need adjuvant therapy for these patients. 205 patients in the control arm, 205 patients treated with capecitabine. It was reported as a positive study, but if you can see the graph, there is actually no difference between capecitabine and observation. But in sensitivity analysis, looking at patients with lymph node metastases, positive margins and so on, there is a difference in survival in these two groups of patients. So I think for a subgroup of patients after surgery, capecitabine may be useful. But I think we can do better than that because after surgery, you've got plenty of tissues. You can actually look for biomarkers. Y90 is widely used. I think Dr. Salem gave a very good talk on this very good therapy. Limited data, so 2 clinical trials are currently running. One is the investigator-initiated trial by the Chinese University of Hong Kong, and very interestingly, a similar trial by Certex itself. So this is combining standard of care therapy, GEMSIS, which will be given following Y90. I think it may make more sense to have immunotherapy following Y90, because after Y90, we know there's significant upregulation of T cells in cancers. So how do we close the gap with clinical trials? I think we need to have a better understanding of tumor heterogeneity and of driver mutations, because we are now hitting in the dark. I think biomarker-driven clinical trials are very important. This can stratify patients, can enrich patients according to disease subtypes or genetic drivers, so that you can really test if a novel therapy is going to be useful. And this is especially useful for adjuvant therapy, because after surgery, the surgeon has plenty of tissues for analysis. You can look at what biomarkers are present and then treat the patients accordingly. So combination therapeutic options are going to be useful in the coming years, I think. So combining, for example, a checkpoint inhibitor with a molecular targeted therapy or checkpoint inhibitor with radiation therapy, I think might be the way to go in this group of patients. But clearly, huge numbers of clinical trials are required for this group of patients in which currently the outcomes, even with surgery, are not good. Thank you very much.
Thank you for this overview. Other questions from the floor? Well, then I would start with one. Maybe you have pointed out the importance of, or the main driver here is the genetic diversity, which underlines the importance of personalized medicine in the future. Can you speculate a little bit how you think future therapies will be tailored to the patients?
I think ideally, all cancer therapy should be tailored to patients. And of course, surgery will always remain the first line of defense, because that is still the best way to treat the patients for many reasons. Because after surgical resection, we are also able to tailor subsequent adjuvant therapy better to the patients because of the tissues that we have after surgical resection. So I think coming forward, I think there should be more clinical trials based on really the genomic subgroups of these patients, because we know now that cholangiocarcinoma is not necessarily only one group of cancer, it's a few cancers together, almost like breast cancer or colorectal cancer, there are subgroups. And to benefit the best, the patient should be treated according to their subgroups, because the driver mutations are different, the behavior is different. I think moving forward, I think that should be the way that we should go. And surgeons would have a very important role to play in this.
Thank you very much. So I would like to continue now here with the case presentation with Dr. Cleary.